Okay, guys, I have discussion D for you. Now we are discussing paying fair wages helps nursing home staff and residents. Okay, so here we go with the presentation I made for you. When I clock in at 6 a.m., the building is already awake with needs that never sleep. A woman in room 214 waits for help to sit up so she can breathe easier. A man in the dementia wing wanders toward the door, searching for a face he remembers from years ago. The tasks are simple in description, but heavy in consequence. Bathing, turning, feeding, listening, noticing the small changes that signal infection or decline. These are the moments that define dignity in the last chapters of life, and they are delivered almost always by certified nurses, certified nursing assistants, and aides whose paychecks do not reflect the weight of their work. This is not a story about charity. It's a story about basic economics and human safety. When direct care workers earn livable, predictable wages, the whole system improves. Staff stay longer. Knowledge accumulates. Knowledge accumulates. And residents receive care from people who know their habits, their medicines, and the subtle cues that separate a routine day from an emergency. Continuity of care is not a luxury. It's a safety net woven from relationships and experience. Paying fair wages strengthens that net. Understaffing is not an abstract matrix. It is the reason a call light goes unanswered for 20 minutes. Why a resident who used to eat well loses weight. Why pressure ulcers appear where alternative turning would have prevented them. High turnover means new faces every few months. And new faces mean loss, institutional memory, family notice, families notice, residents suffer. The moral calculus is simple. Investing in wages is investing in fewer falls, fewer hospital transfers, and more humane days for people who can no longer speak for themselves. There are practical reasons to act now. Many nursing homes rely heavily on Medicaid, which reimburses care at rates that often fail to cover the true cost of quality staffing. For profit ownership models can compound the problem when margins are prioritized. Over investment in people without policy levers that tie public funding to worker compensation, wage increases become a gamble for providers already operating on thin margins. This is why wage reforms must be paired with funding strategies that ensure dollars intended for staff actually reach them. A fair a fair wage also a public health investment. When CNAs can afford stable housing, reliable transportation, and basic health care for their families, they are less likely to miss shifts, less likely to bring illness into the workplace, and more likely to remain in the profession. The ripple effects extend beyond the facility. Stronger local economies, reduced reliance on public assistance, and a workforce that can pursue training and career ladders into licensed nursing roles. In short, paying people what their work is worth creates a, a virtuous cycle of quality and stability. Stipends worry, or skeptics worry that wage mandates will force closures or cut services. Those risks are real. It, reinfor- it reinforms if reforms are implemented in isolation. The solution is not a single policy, but a package. Medicaid rate adjustments tied to enforceable wage pass throughs, transitional stabilization grants for small providers, and transparent auditing to prevent diversions of funds, phased implementation, and targeted supports can protect rural and nonprofit homes that lack scale while still raising standards across the board. Beyond policy mechanics, there is a moral clarity to this work. Caring for older adults and people with disabilities is, is a cornerstone of compassionate society, of a compassionate society. The people who do this work deserve more than gratitude and applause. Just we honor both the worker and the resident, and when we make a public statement about the kind of community we want to be, the pathway forward, the path forward requires political will, careful budgeting, and consolidation. Coalition building among families, providers, workers, and policymakers. It also requires a shift in how we value care, work, and in public disclosures. If we measure success only by short term savings, we will continue to pay higher price in human suffering and avoidable medical costs. If we measure success by the dignity and safety of our most vulnerable neighbors, investing in wages becomes an obvious and urgent priority. In the end, paying fair wages is not an expense to be minimized. It's an investment in safety, continuity, and the simple human promise that people who care for our elders will be cared for in return. Pennsylvania's LTSS system is under simultaneous pressure from demographics, Medicaid dependence, and uneven HCBS capacity, with stark regional variation between urban centers and aging rural counties like northwestern Pennsylvania. Reform here is less about investing something and new than aligning financing, HCBS infrastructure, and workforce policy around a coherent statewide strategy. Key structural changes in Pennsylvania: Medicaid heavy financing. Medicaid is the dominant LTSS payer, especially for nursing facilities with county based aging networks and waiver programs carrying most HCBS. Middle income, middle income older adults face a steep cliff. Too rich for Medicaid, too poor for private LTSS markets. Nursing facilities, nursing facility dependence, and uneven HCBS access. Legacy resilience on nursing homes remains high, particularly in rural regions, while HCBS capacity, personal care, adult day programs, and home health care management is patchy and fragile. Discharge planning from hospitals is uh, constrained by limited home based options and workforce shortages, driving avoidable length of stay, workforce fragility. Direct care workers lag behind hospital and uh, SNF rates. Agencies struggle with vacancy and turnover, and transportation barrier compound recruitment in rural counties. This is the single biggest operational bottleneck for both HCBS and facility based care. Fragmented governance, aging services, Medicaid behavioral health, and IDD are spread across multiple agencies and county structures, making coordinated LTSS strategy difficult and slowing innovation. Emerging opportunities and levers, Medicaid rebalancing and rate reform. Increase rates with wage pass through tied to transparent reporting. Use value-based purchasing to reward reduced hospitalizations, successful transitions, home and caregiver supports. Target rebalancing funds to counties with high nursing home utilization and low HCBS. Okay, guys, that is your shows for now. I will see everybody tomorrow for shows. Until then, Gator Wellness. Take care. Hi, Pammy.